My name is Alex Nissen. I think I've met everybody here this morning for a case conference. We'll just kind of jump right in, discuss the case, some surgical options, and then focus pretty heavily on a approach for revisional paraesophageal hernia repair that is not frequently seen in general surgery clinics, and kind of go from there. Thanks for showing up, Dr. Percival, for some additional thoracic surgical expertise. So to begin, we have a 68-year-old woman who's presenting to the general surgery clinic really with worsening reflux symptoms since about mid-2020. She was recently seen by GI for some of these symptoms and had an EGD performed that was notable for evidence of a recurrent hiatal hernia and possible slip Nissen fundoplication. Yes, sir.
I really don't understand. What does a slip Nissen?
So I will get to kind of, I have a slides on kind of modes of failure because it is important, I think, to be very clear about herniated Nissen versus slip Nissen and all those sorts of things. But she has GERD symptoms despite high dose BID PPIs, and she also notes occasional solid and liquid dysphagia. In terms of her pertinent past surgical history, she had an open umbilical hernia repair in childhood, and then really the most pertinent surgical history begins in 1997, where she underwent an open Nissen fundoplication with a callus gastroplasty. That course actually having been complicated by the need to return to the operating room on postoperative day 2 for a retained lap sponge. After which she had a long period of resolution of her index GERD symptoms before her recurrent symptoms for which she's being seen in clinic most recently. She also underwent a laparoscopic ventral hernia repair with an intraperitoneal onlay placement of synthetic coated mesh of a size 20 by 30 centimeters in 2010. That surgery also had several kind of areas of midline hernia defects, some of which were able to be closed, some of which are really being bridged by this mesh, and then a posterior lumbar fusion. Her past medical history that remains is fairly unremarkable. Her medications are appropriate for her comorbidities and then otherwise kind of non-contributory. In terms of additional data, as we're able to obtain it, her 1997 op report has not been obtained, and I've been unable to locate it, but her 2010 op report is notable for some difficult entry into the abdomen with various sites of attempted varus entry, ultimately culminating in a right upper quadrant cut down and mention of some significant adhesions, though the procedure did stay laparoscopic without converting to open. When you're seeing her in clinic, her vital signs are normal. Really, her exam is non-contributory. It's fairly benign. In terms of her additional data, her EGD, some representative images being shown here. This is maybe not the most impressive, but what is being deemed a Cameron's ulceration kind of right here. And then you can see this is, an antegrade view still within the hernia sac, but then this is a retroflex view, again, showing a sizable paraesophageal or hiatal hernia with some debris and kind of old food and actually some pill debris within the hiatal hernia. Yes, sir. I'm sorry? I believe that'd be grade Hill grades. Grade 3 laxity? No? Okay. In terms of a chest x-ray is done as the initial scout film of her upper GI. You can again see kind of a retrocardiac opacity with some air fluid level right at kind of the hiatus consistent with her known hiatal hernia. And then in terms of selecting a relevant image, you can see that there is obviously a hiatal hernia. It appears that maybe her RAP is in this neighborhood, just supradiaphragmatic. There was also noted to be some tertiary contractions in the esophagus during this swallow study. Her CT scan that was obtained just for better delineation of her postoperative anatomy was ordered from clinic. It was non-contrasted. And you can see here, obviously, a fairly sizable recurrent hiatal hernia. This is the old staple line, likely from her previous callus gastroplasty. You can also see really there's no fat planes at certain areas between the stomach and the liver, as the left lobe of the liver is frequently fairly adherent to the anterior wall of the stomach in these cases. This is really just a sagittal view showing the same thing and exactly where that callus gastroplasty staple line is sitting. And then the purpose of this lower view is not anything related to the stomach, but if this looks like fascia, it's actually just an area of bridging mesh in the supraumbilical region where you might be thinking of placing a trocar if one was to do a laparoscopic redo Nissen. So just a brief word about modes of fundoplication failure, like Dr. Percival was asking about. It's important to be really clear when we discuss these and kind of stick to the right terminology because it's important in terms of what was probably done right or wrong the first time and how one plans to address it. But there are wrap dehiscence and wraps being too tight. But really the most common mode of failure is going to be a slip fundoplication or a herniation. In this case, our patient really has both. A slip fundoplication typically indicating some component of stomach that has risen above the wrap, as opposed to a wrap that remains around the GEJ. This can also be confused for a malplaced wrap in the first place. Sometimes, for instance, less experienced surgeons may inadvertently wrap really the cardia as opposed to the GEJ to begin with. And then a herniated wrap being one that rests in the chest. This patient really had evidence of both, with some component of her stomach above her wrap and then the entirety of that sort of complex being herniated into her chest. So just to summarize, we have a 68-year-old woman with a previous openness and fundoplication and callus gastroplasty, permanent mesh in the IPOM position after ventral hernia repair, who's presenting with a failed fundoplication and recurrent paraesophageal hernia, symptomatic with medically refractory reflux, some dysphagia, and endoscopic evidence of Cameron's ulcerations. And so in terms of thinking about how to approach this, the treatment goals for her are fairly numerous, but we obviously want to address both her symptoms and her reasons for this anatomic dysfunction, her symptoms being primarily reflux with some component of dysphagia, and then the anatomic reasons for these being her recurrent paraesophageal hernia, obviously, though she may have some evidence of a shortened esophagus, which can affect one's operative approach of choice. And then the Cameron's ulcerations, though she does not have anemia or other evidence of active upper GI bleeding, are concerning and another indication for a possible surgical repair. In terms of avoidance of lifelong medications and the associated side effects, she is not really having necessarily side effects of PPIs, but that can be a secondary reason, though somewhat of a weaker reason to entertain revisional foregut surgery alone. So in terms of the options, I won't belabor all of these, but there are a number of them from kind of least invasive to more invasive. A number of the upper ones really are not great options, and for several reasons. So medical management is what she's currently undergoing. It appears to be inadequate in terms of her current symptom control, and it really does nothing to address her dysphagia or her Cameron's ulcerations. In terms of endoscopic options for management, Stretta is an endoscopic radiofrequency probe that really is used at multiple levels to induce kind of a fibrotic response about the GEJ. It really, again, does nothing to address her recurrent paraesophageal hernia, and it does not address her dysphagia or Cameron's ulcerations. It may be kind of an adjunctive technique for isolated recurrent reflux disease. In terms of gastropexy or double peg to secure the stomach within an intra-abdominal position, if she was considered a prohibitive risk patient for a surgical repair, this would also be complicated by the fact that she has a very large piece of synthetic mesh through which your peg or pegs might be placed, and this could contaminate the mesh and create a whole new problem. In terms of transabdominal redo paraesophageal hernia repair with fundoplication versus any form of a lynx, she again has this bridging mesh at sites where one might plan to be placing trocars, and based on the description at the time of her ventral hernia repair, she may have what could be considered a hostile abdomen, though that's sort of operator dependent, I would say. So an option that's not probably talked about very frequently, it's also not performed very frequently, though, is the transthoracic approach to paraesophageal hernia repair with a fundoplication, also called a Belsey Mark IV. It's really originally described, kind of conceptualized in the 50s and 60s. This is one of the original descriptions by Dr. Belsey's group. It was a case series really of over 1,000 cases, 632 of which were Belsey Mark IV repairs. And then just before we get into the actual technical steps of the operation, his original kind of technical principles proposed in this techniques article that he wrote back in 77 are still very germane and kind of identical to what you might remember from when Dr. Schaffner gave his GERD lecture just a week ago, being kind of the reestablishment of the acute esophageal angle at the cardia, shortening and strengthening the crural sling for sort of the pinch aspect at that same area, and then restoration of the LES into the high pressure zone of the abdomen. It's really kind of the same principles that haven't changed with time. So as this procedure is performed, it's typically done in an open fashion through a left posterior lateral thoracotomy. So the patient would be positioned right lateral to cubitus. As with any thoracotomy, it's a bit of a lower thoracotomy approach because, again, we're trying to approach the hiatus, not really something higher up in the chest. And then really to just kind of march through step by step. These are kind of images from a more recent op techniques article, and then this is from the original kind of Skinner and Belsey article to try to juxtapose them. But so initially one would isolate the esophagus, predominantly bluntly sling it with a Penrose train if able, isolate the phrenoesophageal fat pad and resect it. And really, the description involves isolation of the esophagus all the way from the hiatus up to the aortic arch to achieve adequate mobilization and length. Shown here in this image, diaphragm, stomach, fat pad, heart, aorta, esophagus, just to orient everybody. After which, once you sort of define your area of crural defect and are able to mobilize it sufficiently, you place kind of your first of 3 rows of sutures. This row will eventually be used to repair the crural defect, and after they're thrown, they're left loose and snapped and set aside. But you want to bring them across your area of proposed crural closure, set them aside, and then you'll use those to tighten your cruroplasty after you've kind of fully performed your fundoplication and reduced the stomach into the abdomen with sufficient esophageal length. So the first of your kind of 2 rows of real fundoplication sutures comes into play now. And these are a total of at least 3 horizontal mattress sutures taken from stomach towards esophagus, back out, and then back out the stomach. The general rule is to start about 2 centimeters below the GEJ, go up on the esophagus about 2 centimeters above, and come back out. With these sutures, you'll form really kind of a 270-degree anterior fundoplication that will sort of telescope or invaginate the esophagus and GEJ to create that acute angle back at the cardia of the stomach again. And then after this, these are tied and secured. So you have this initial position, but obviously the stomach and esophagus are above the diaphragmatic hiatus in this picture. And so you have to get them below with your next row of sutures. The next step, the original description is actually with a spoon retractor. This is what it looks like. It's just a spoon in the operating room when Dr. Belsey was doing these cases. But you can just use a malleable, but you'll take, again, kind of mattress sutures, this time through diaphragm, stomach, esophagus, and back out. Probably the closest thing it's analogous to would be almost when you're brooking an ileostomy, if you can imagine that. And so once these are placed, you have kind of this first row of sutures that has been tied, this cruroplasty suture that is set aside and will be tied later, and then your third row of sutures that really does the kind of dunking aspect of setting this within the abdomen. And again, these will be taken through the diaphragm, an additional 2 centimeters below your original gastric suture line, and then typically an additional 2 or so centimeters above your original esophageal suture line. With an assistant's hand and a bougie in place, you can dunk this into the abdomen and tie these sutures. And now you have clearly kind of diaphragm well over the esophagus. There's no visualization of the GEJ anymore in the chest. And then you can tie your posterior crural sutures. And so just to offer kind of another view of what's created, these are your first row of sutures that are tied last in the crura. Your second row of sutures here, that's really creating kind of that acute angle. And then the third row, that's really, forcing everything into the abdomen for the repair. Just trying to visualize this for anybody that's not seen it before. I know it's a very uncommon procedure. I've not seen one before either. And then this is just the last image kind of in color, showing the same things, really. A resection of a large hernia sac. Once you can isolate the stomach, fully mobilize it, you have your crural sutures. This is with everything tied back down into the abdomen. And so this sounds great. It's obviously a big open operation, but what is really kind of the data behind this? And so the original descriptions are really a paper reported by Mark Oringer out of Michigan, but he wrote it kind of on behalf of Dr. Belsey. And this is the first large report of a series of 892 patients in the 50s and 60s that underwent this operation. They actually had pretty remarkable follow-up. It was 86% complete, with a large number of patients being followed for over a decade, actually. The overall recurrence rate was in the 11% range, and for those that were followed for at least a decade, it was about 14%. In those that they labeled as having, quote, unsatisfactory results or really recurrence, they were managed a variety of means. About a third of them managed medically, a number of them managed really with no specific intervention and just kind of lifestyle adjustment and symptomatic management. And then 45 of them underwent repeated procedures, about half of which included repeat Belsey Mark IV operations with or without some additional procedures as shown here. A couple of them also underwent esophagectomy with various kind of conduits of interposition, and they actually describe all this in the article. It's pretty interesting. In terms of more modern series, probably the oldest one that is still kind of germane to what we're talking about today is out of Emory, and this is one that included about 276 repairs. Only about 15% of them involved revisional foregut surgery. The majority having been done for GERD, but there was also a large number done for achalasia and epiphrenic diverticula, which would not have really pertain to our patient today. And they also had a large number of concomitant procedures, namely Heller's and dilations for strictures and achalasia. There was one perioperative death and overall a 10% complication rate. Their pulmonary complication rate was fairly low, as you can see here, about 1 to 2%. There was a fairly significant number of atrial arrhythmias in a couple percent of patients. And then they did have a fair number of reoperations. Some were early for either immediate failure or for bleeding. And then those at 9 months to 4 years were really operations for true recurrence, as you would imagine. However, in their long-term follow-up, a lot of this, though, being kind of telephonic and survey-based, was 84% of patients had absent or minimal symptoms, though this follow-up was not nearly as complete as Belsey's original series. Again, though, both of these series really describe primary repairs through the chest. It's not necessarily revisional surgery through the chest like our patient is undergoing it. So the largest series that would address that would be this. It's a retrospective review from a single cohort in the Netherlands, actually, where they collected this cohort prospectively, retrospectively reviewed them. It was 130 patients who underwent 144 operations, the vast majority being for reflux and about a third for dysphagia. The majority of patients had prior Nissen fundoplications, and the common mode of failure was kind of as described in this patient, being slippage with a lesser degree of wrap disruption. In terms of who got redo Nissen versus who got Belsey Mark IV, their description was that it was the group's preference for essentially where the wrap was lying. If it lied in the chest, they would approach it through the chest. If it lied in the abdomen, they would approach it in the abdomen. And there was one surgeon that did all of the Belsey Mark IVs and 2 that did the redo fundoplications. In terms of their perioperative complications, these are certainly higher, but in terms of their rate of leak, it was as high as 15%. They really don't describe the number of leaks that required subsequent operative intervention versus those that were managed expectantly with drainage and NPO status and those sorts of things. There were another collection of patients that had superficial injuries that required discrete management during the time of the operation. About 6 patients had splenic injuries. 3 of those required splenectomy, and their pulmonary complication rate, which was again left somewhat vague, but included both significant atelectasis and pneumonia, was in the 4 to 5% range. Their bleeding and mortality figures are shown there. Their mean length of stay, and this is because a number of their Nissens were performed open, only 16 of these were redos that were done laparoscopically, was 8 days in the Nissen cohort and 14 in the Belsey cohort. When considering some of the complications, you can see them here for those interested as well, just in greater level of detail. But their overall resolution of symptoms that they quoted in terms of both subjective and objective follow-up of these patients when seeing them in clinic, and then objectively scoping them, repeating upper GI studies, and repeated manometry and pH testing, was about 70% for both. But it's important to note that really there was a very imperfect overlap, and of those that had dysphagia, especially as one of their pre-op symptoms, whether or not they had subjective resolution overlapped with whether or not they had objective resolution of their symptoms only about 50% of the time. So some patients would feel great and not actually have objective resolution of their dysphagia, or vice versa. And so one could quote a patient a 70% recurrence or a 70% resolution of their symptoms, but it's important to know exactly what they're asking about and what you're telling them about when you're counseling these patients. And really kind of the last study that I have to go through, I know I'm kind of moving quickly though, is this series out of Mayo Clinic in 2018. It's probably the most contemporary series. It's a relatively large retrospective review of a decade of patients that involved 118 matched pairs who underwent either redo laparoscopic Nissen fundoplication, or excuse me, either laparoscopic Nissen fundoplication or a Belsey Mark IV. This series included only quote unquote large paraesophageal herniae, the definition that was provided being when at least 50% of the stomach was in the chest. The vast majority of, I'll get to that. But so for their outcomes that they found, there was a non-significant but higher numeric recurrence rate for laparoscopic Nissen fundoplication at 16% versus the Belsey. Their duration of follow-up is actually not listed in this paper, so I can't tell you over what time period this is. Lots of it is kind of survey-based, telephonic. At Mayo, I think a lot of patients travel there for their care. And so, in terms of their true in-person follow-up, it's a bit difficult to make, exact sense of that. The significant difference, though, was most notable really in terms of gastroesophageal leak at about 7% in the redo Nissen group versus a reported 0% in the Belsey Mark IV group, for what that's worth. Respiratory complications were non-significantly but numerically higher in the Belsey cohort, as you can imagine. And then their need for reoperation was approaching significance at about 9% versus 2.5% in the Belsey group. Now, whether that's that a patient truly needed and got a reoperation versus a patient needed a reoperation, had a prior Belsey, and so one was loath to reoperate on that patient, I think is very difficult to tease out. And then in terms of their GERD health-related quality of life scores were similar and quoted as excellent in about 75 to 80% of patients. Their mean length of stay was, I think, much more in line with what one would expect for a laparoscopic approach today. For the Nissens, about 3 days, and for the Belseys, about 6 days. But the caveat being that in the Belsey group, again, one surgeon performed 94% of these Belsey operations. I'm sorry? This is it. Yep. And then, so really, I was going to end with a summary slide, and we have a lot of faculty here to add expertise and chime in, but yes, sir.
I have a question.
Her BMI was 31. So, I mean, I think, to be honest, if I didn't have a thoracic surgeon to back me up right now as a general surgery resident, I would really only probably feel comfortable offering this patient a redo lap Nissen fundoplication, just because that's what I've done most. I'm sorry. It's difficult to say. I think if I had someone that was going to scrub with me, then I think a Belsey would be reasonable. The one thing that will be difficult through her chest is if she needs a redo collis for any reason, I think, because in terms of, I think because her staple line looks densely adhered to the liver, which is infradiaphragmatic and going to be difficult maybe to fully access. You could certainly increase the size of your crural defect and fix it later just to safely visualize what you're about to do.
Okay, so do you have to do a Belsey through the chest? Is that the only repair you can do through the chest?
There are descriptions of transthoracic Nissens as well. Is that what you're getting at? Or
That's exactly what I'm getting at.
Yeah.
So what I'm asking is, would you do a Belsey Mark IV through the chest?
as opposed to doing one through the abdomen, yes, but that's not your question. I think it would be reasonable to also offer her probably, I would say, a toupee through the chest, given her preoperative dysphagia.
Okay, so I will tell you, I've done one Belsey Mark IV. All the readings I've done through the chest, I just do toupees.
Okay.
And somehow it magically works.
Okay.
Yeah.